I'm Mark Pegram. I'm the Associate Director for Clinical Research at the Stanford Comprehensive Cancer Institute here in Palo Alto, California. Well, immune compromised is simply the state of being more vulnerable to infection. For example, during chemotherapy, cancer patients can become immunocompromised due to the side effects of chemo. However, the good news, even in chemo-treated patients, is that most of the serious infections that we see are actually from outgrowth of endogenous bacteria in the patient's own gastrointestinal tract. That's the highest risk for fever due to low white counts caused by chemo. Viral infections, on the other hand, are usually managed pretty well by chemotherapy patients with cancer, although common colds, et cetera, may persist for a day or two longer, but usually they are cleared even in patients on active chemo without too much fanfare. It's ironic that this COVID-19 situation has arisen right now because we just recently published a paper here at Stanford to study immune reconstitution in patients with breast cancer after breast cancer chemotherapy. And we found that almost all the immune functions seem to be restored by about 1 year after chemo. However, there were detectable defects in so-called helper T cells. These are the T cells that help your body to make antibodies. They help to activate killer cytotoxic T cells and macrophages, which are kind of like the garbage collectors of the immune system. And also, these helper T cells can be particularly useful to maintain mucosal integrity, like mucosal barriers, like in your mouth, in your throat, in your bronchial tubes, in the gut, et cetera. And so these findings, this defect in helper T cells, could have implications for response to vaccinations or response to infections. So it's primarily the chemo-treated patients we're most concerned about, or steroid medications, or mTOR inhibitors in the case of breast cancer patients. Some of these have been shown to be general immunosuppressants and can lead to immune compromise in our breast cancer patients. While there are no studies on COVID-19 in cancer patients in particular, we consider cancer in and of itself generally to be considered an immunocompromised state to some degree. And like I said, cancer treatments like chemotherapies, steroids, CDK inhibitors, mTOR inhibitors, those types of medications have been shown to lower immunity to some degree. By virtue of the fact that cancer patients may come into contact with healthcare professionals, by definition, they are higher risk to contract COVID-19 infection because all of us in a hospital and clinic situation are also, the personnel are considered high risk because of the number of people that we come face to face to during the day. So mitigation of this risk we think is important. So in our clinic, we're deferring all non-essential clinic follow-up visits and laboratories, including screening imaging tests, but not diagnostic imaging. And for many clinical encounters that must occur for safety's sake and to make sure we don't lose sight of the mission to eradicate the cancer and maintain the best possible outcomes in our cancer patients, we're considering web-based or video virtual encounters, and oftentimes that can suffice in lieu of a face-to-face visit for an immunocompromised patient. Well, I think there's good news for patients who are on oral treatments. Number one, they can take their treatment at home, and so there's less of a need to come into contact with, let's say, nurses at an infusion center, et cetera. So that's good news. Moreover, many of the oral cancer therapies, particularly in breast cancer, are endocrine therapies like tamoxifen or aromatase inhibitors, and these drugs are indeed not immunosuppressive. So there's no danger to continue your oral cancer treatments in many instances. Even some oral chemo drugs like capecitabine, also called Xeloda, for instance, are not particularly immunosuppressive to any great degree, and we can adjust the dose of such medications based on the white blood cell count in a given patient. So they may still need to make treatments to the, visits to the laboratory to check blood counts, etc. But in general, oral medications frequently don't require face-to-face clinic visits and can be done by a virtual encounter instead. Also, I would try home delivery of your medication refills if that's available through your pharmacy. Otherwise, if your pharmacy has a drive-through option for pickup, use that. We've even done some drive-by pickups of clinical trial oral drugs at the Stanford campus, where we just simply meet the patients at the curb, give them their next batch of oral medication, and off they go, and they don't even have to set foot in the building. The other consideration is whether the oral drug you're taking is absolutely essential. For some patients, for example, with ER-positive metastatic breast cancer, they could do well on for a time on endocrine therapy alone and save drugs like CDK4/6 inhibitors for maybe later after the risk of COVID-19 transmission has been reduced. For cancer patients, the answer is probably not. For precancerous conditions like ductal carcinoma in situ or DCIS for the breast, that is a condition that may well be able to be controlled for a long period of time without starting any specific therapy like surgery or radiation. But your treatment can potentially be modified to minimize risk of COVID-19 transmission. So ask your doctor whether there may be de-escalation strategies for your type or stage of cancer that can buy time prior to the need for chemotherapy or surgery. For example, preoperative or neoadjuvant endocrine therapy may buy you 6 months of time to stall the need for surgery or any other type of therapy, for instance, in ER-positive, newly diagnosed breast cancers. And like I said, for ductal carcinoma in situ, for most patients, a watch and wait strategy would not be a problem. If you must start chemotherapy in a curative sense, for example, ask your doctor which regimens have the fewest visits to the infusion center. For example, instead of taking Taxol or paclitaxel on a weekly intravenous schedule, you might be able to just take a higher dose once every 3 weeks instead and get similar efficacy and also outstanding tolerability. Also, we're using more growth factors for chemo regimens also these days to reduce the risk of infectious complications after chemo by boosting the white blood cell count to higher levels. And finally, for radiation therapy, there are approaches like intraoperative radiation therapy where you get just one dose in the operating room for highly selected patients. That might be an option. And then shortened radiation schedules may also be considered by your radiation oncology team. So ask if you qualify for one of these accelerated schedules where you might be able to finish the radiation in just half the time with a lot fewer visits and therefore decreased encounters with medical professionals and reduced risk of viral spread. And then finally, if there's a clinical trial option, take that into consideration if it's still available at your institution. Many trials are now allowing certain protocol deviations to make the protocols more user-friendly, so clinical trials may still be an option for selected patients. Again, this really depends on risk. So it's very important to ask your doctor specifically which tests are quote unquote essential and which ones might be able to be comfortably deferred for the next few months. For many patients, routine cancer screening can safely be delayed for the next few months until the viral transmission rates in the US are decreased. Moreover, in breast cancer in particular, it's been shown in a randomized trial published in the Journal of the American Medical Association years ago that intensive follow-up is no better than routine clinical follow-up visits, intensive meaning scans and biomarker blood tests, et cetera. The outcomes are the same whether you have intensive follow-up for breast cancer or just routine history and physical type follow-ups with minimal imaging or blood testing. So taking that study results into account, surveillance after finishing your primary cancer therapy may be minimal and still be as effective as intense scanning. Screening mammography, for example, for most patients can probably be deferred. However, diagnostic mammography or other imaging like MRI or sono, if there's a detectable problem, like something that you can feel or see on examination, those should not be deferred. Absolutely, you must proceed with those diagnostic imaging procedures that are necessary to detect and facilitate diagnosis and treatment of cancer.